Today, our topic is overcome complex coronary interventions with the Novel Alveo 0.75 CTO balloon. We are very honored to invite four respected professors from Netherlands and Poland. They are Dr. Trouble Name, Dr. Wassim Shatila, Dr. Jan Brugger, Dr. Greg Girls from Poland. Welcome.
So I'm sharing right now my screen. Can you see it?
Yes.
Yes, it's working.
Okay, perfect. So thank you for inviting me. Thank you for everyone. I'll be talking about just a little bit about techniques to cross difficult lesions and my experience with Alveo 0.75. So uncrossable lesions are those that cannot be crossed with a balloon after crossing with a guide wire. So you're able to cross with a guide wire, but you cannot pass your balloon. And this is encountered up to 9% of all CTO interventions, and it's the second most common barrier after inability to cross the lesion with a wire. So usually they're calcified lesions or very tortuous and have a high JCTO score. This makes what the cost is. There's usually more radiation, more contrast, longer procedure times. And this is why using different techniques will help us reduce this increased radiation and improve patient outcomes. So the first line strategy usually is using a more supportive catheter. So using an XB, EBU, something with a backup support or an AL guide or other guides that you can use. The more support you have, for example, like the AL, the more you are able to cross the lesion. Larger French guides, also 7 or 8, also gives you more support and helps you be ready for kissing technique strategies and further cases. So the second line, first we use a more supportive guide. Second, we're trying to use a small semi-compliant balloon from 0.85 to 1.5. This is initially the algorithm, and then we prepare with a bigger NC balloon. And this is where the Alveo HP comes into play. It's actually, they have a big portfolio between 0.75 to 2, and so now the Alveo 0.75 is an excellent add. It has a very small crossing profile and an entry profile also, so 0.0156 inch, so a little bit bigger than the wire. It has the RBP is 20 atmosphere, rapid exchange design, and it has the hydrophilic external coating and the eel silicone internal coating within the guide wire lumen. I'm not going to talk much about this because everyone talked about the new features of the Alveo HP 0.75, the ultra low tip profile, and how it can easily cross those complex lesions and help prepare them for further dilatation and hopefully stent implantation. So I just will tell you, this is a patient, this is an old cardiac cath. This is actually 2 years prior to presenting to me. So I saw him 2 years prior. He had some LAD disease, which we stented, but he had some distal circ disease, which I was showing here, and distal RCA disease. So we finished this. So you see here, he had some distal circ disease. We left for medical therapy, and we just treated the LAD. So here, the distal circ lesion. And he had the small RCA, we'll show you here in other views. Small RCA, some disease, so it's also medical therapy, it's a small vessel. But the patient came back to me 2 years later complaining of significant exertional angina. This is limiting his daily activities. And so we decided to repeat the cardiac cath for him. So the repeat cardiac cath for him. This is the same video too. So we'll show here distally the circ is, the stents are patent, however, distal circ, we'll show with another. So you can see here, sorry, it's replaying. I'll show you the other image. So distal circ here, the disease is much worse. It's diffuse in nature. The LAD stent is patent. And the RCA, you have a tight lesion, a subtotal occlusion. It's a subtotal occlusion. So consequently, given his symptoms and given that the prior stents are patent and he failed medical therapy, we decided to actually do intervention for the RCA and distal circ. So the RCA initially started with a JR, then we switched to an AL because the balloons would not cross. We had to use the Alveo 0.75 balloon, which had, as you can see it here, it's actually crossed quickly. No other balloons would cross with us. It crossed quickly. We were able to pre-dilate all this lesions, and this is post-dilatation. You can see there's a better lumen. Then we prepped it with a 2.0 balloon, 2.012 balloon, and then we placed a stent with a very good result actually. The distal circ, which would not have intervened upon if not for his significant symptoms. We went in with an Alveo balloon, a small balloon, to be able to pre-dilate because also distal lesion, and then we were able to easily pass two long stents actually, which are usually difficult to navigate in distal circ, and we had an excellent outcome, really with no problems. And these lesions before, we'd spent so much time trying to cross with bigger CTO balloons, with bigger profiles without much success. So we tried the small balloons, we tried a more supportive catheter. Let's say if all fails, you can use a guide extension to help deeper intubation and smoother pathway into the lesion. And how you advance your guide also depends. You can use a balloon inflated in front of it, or you can, and then try to advance it, or you can have the balloon in front of it and then deflate and then advance your microcatheter. This helps deeper intubation without dissecting the lumen of the coronaries and help us deliver the devices. There's also, you can use extra supportive wires or a body wire for increased support. And this is a so-called wire cutting technique where you have two wires within the lesion. The balloon is not crossing. You actually inflate a balloon and trap one of the other wires, and then you pull back the wire. When you're pulling back the wire, it actually works like a blade and tries to cut the inside of the lesion, helping to prepare the lesion for further passage. Anchoring technique, okay, let's say despite everything, you're still having your guide being kicked out, you can put a small balloon in a branch vessel and inflate it to help anchor your guide inside. You can use microcatheters also to help penetrate those lesions if nothing else is going through. And then microcatheter can be a preparation for the small balloons, the Alveo small balloon, and then go up with further balloon dilatation. Really preparing the lesion helps for safer procedure. And then you can use atherectomy, of course, if it's a very calcified lesion. There's rotation and direction atherectomy, or laser atherectomy is one possibility. And there is also, when you intentionally burst the balloon, you can also cause microdissection in this area. It's not the safest procedure, but it's one technique to do. Dissection re-entry across the lesion. This will not be actually technically crossing the lesion, to cross it. And there's the scratch and go. You scratch the subintimal space with a heavy tip wire, and then you go in with a safer wire to penetrate the subintimal space. So using good support is key, but also using a low profile crossing balloon is very important to help us cross those usually uncrossable lesions, and to further dilate them in preparation for larger balloons and consequently stent deployment. This facilitates CTO procedures, reduces procedure time, radiation time, patient satisfaction, and physician satisfaction. So thank you.
Thank you, Dr. Shatila.
Thank you, Wassim.
Thank you.
So, Wassim, how did you find the difference between using Alveo high pressure and other balloons? Did you notice?
I did actually. I used to use other CTO balloons. I used to use other CTO balloons actually, and there was a huge difference because the other CTO, they're small, but their crossability is, some of them are terrible. They would not cross the lesion to be able to predilate. But this, I felt it gave me both easy crossability and good dilatation. So it was really a big difference for me.
Doctor, I got one question. How often do you go retrograde when you do the procedure?
Not very often using retrograde, also because of the equipment that we have available. Everything is not very much. I've used it sometimes retrograde technique, but not much.
Okay, thank you. But how do you find the situation when you have no other way but you have to go retrograde? And have you ever been in the situation when you have the balloon too big entry profile that you cannot even think about it?
Yes.
And now when you have this small balloon, would you consider to have more options during the procedure?
I agree, especially when you're crossing this, going through the septals and going all the way retrograde. I think this actually offers a huge benefit to help predilate those lesions and go from a retrograde approach. So yes, I think it gives. I think it's a huge change for us.
Okay, thank you.
Dr. Shatila, I have a question for you. It's a technical question, maybe. You know, the balloon is the lowest profile that we use. So I have a technical problem here is how to see or if you have any tips and tricks, how to prepare this balloon, to see this balloon under X-ray during the ablation. So this is a problem for, I don't know if you have any tips and tricks to have a special preparation for this balloon, to see this balloon while inflating it.
So for me, actually, so this is a middle marker balloon, so you have to really target the middle marker inside of your lesion. That's how you have to see it. It also depends. I mean, for me, the middle marker was clear enough for me to be able to use it. That's how I'm preparing it. I'm not so otherwise. Once you inflate it, you'll see some mild contrast, but you have to really concentrate on the middle marker where it is to be able to look to properly position it.
Yeah.
And also, of course, your views. I mean, especially in obese patients, how you have to. The more obese the patient is, and the more caudal views you have, maybe the less penetration you have, and the less imaging clarity you have.
Okay.
Thank you, Wassim. Very nice cases.
Thank you so much. Thank you.
Thank you, Dr. Shatila.
Thank you. And Dr. Wassim, I see one question from Alan. And may I have your idea for practical clinical significance of Alveo, the ultra-low profile in CTO lesion?
So I think the clinical significance is, as we said, CTO lesions, first is to cross the lesion, whether antegrade or retrograde. After you cross the lesion with a wire, the game is not done because, microcatheter might help, but you also have to have a balloon crossing. And you're going directly with a 2.0 or 1.5 balloon, sometimes you don't cross, and it will be very sad if you can cross the lesion with a wire, but cannot cross with a balloon. And that's why the ultra-low profile balloon is a stepway between crossing the lesion and advancing larger balloons. And that's what happened with me, actually. Initially, I tried with a little bit, tried with bigger balloons. It does not go through these lesions. You have to use the 0.75, and then after that, the 2.0 balloon went in easily. So a big jump to have the 2.0 balloon go in easily after preparing this lesion.
Okay. And thank you, Dr. Wassim, for sharing us the strategies when we need a heavily classified torture and higher CTO. It's very helpful for us. Thank you again.
Thank you, Michelle. Also, thank you, Wassim. If I may add, what's very significant with this balloon is its double-fold configuration. So it's very slick as compared to other CTO balloons, and the support you need to cross a usually uncrossable lesion with other balloons is much lesser with this HP balloon.
Totally agree.
So whenever you have a strong guiding, big French guiding, side branch anchoring, whatever you have, and you face a lot of problems, it usually summarizes all the way, and it usually avoids all the other steps. If you take it up front, you will, like Wassim said, you will cut the time of the procedure and you will save the patient from manageable complications, I guess.
And also help the physician with shorter time.
Thanks for our experts and all the audience again. And for more information, you can search BrosMed medical website. And any question, you also can contact us via email, sales@brosmed.com. Thank you.